We just wrapped up cancers of the GI. We finished up our colon cancer. Now we're going to move beyond the GI tract and into the accessory organs of digestion. So those are the pancreas, gallbladder, and the liver. And remember, that liver does everything. That liver has its fingers in a lot of pies. It's controlling so much in your body. So we're going to really want to understand that impact of liver disease when we get to that liver. So let's start with the pancreas. We'll talk about the endocrine aspect of the pancreas later. Today we're talking about the exocrine aspect of the pancreas. The part of the pancreas that is exocrine is contributing to digestion. What's in a pancreatic fluid? Enzymes. So, for example, pancreatic amylases. You'll have some proteases, things that break down our proteins and our carbohydrates. And then from our gallbladder, what's that going to contain? Chyme is going to have what? Bile salts, exactly. And that's actually going to help us break down and transport fats. So we're still back on this idea of macromolecules of life. You see why I put micromolecules today? How well it fits? It's good stuff, right? Okay, so we're back in the pancreas. You do have a pancreatico-biliary system. So that gallbladder is associated with the pancreas, and they're going to secrete fluid. You're going to secrete bile from the gallbladder. It's going to go through that common bile duct into the head of the pancreas, meet up with our pancreatic duct, and we're going to have this hepatopancreatic ampulla. Does anybody remember the old school term for that hepatopancreatic ampulla? It's very Star Wars. It's not written up there. Batter, yeah. Oh, it is all written up there. I'm filled with lies. So the duodenal papilla of Vater, V-A-T-E-R instead of Vader, but pronounced similarly. So we have this connection between the bile and the pancreatic fluid. Pancreatic fluid also, by the way, is alkaline, and that's going to help neutralize the stomach acid that's coming from that duodenum, or from that stomach, rather. Okay. Remember, your bile is going to contain bile acids, pigment, cholesterol, phospholipids, and we're going to use those bile salts to break down lipids and transport them. We're also getting rid of some specific waste products. Bilirubin being very, very significant to us later. Some immunoglobulins, some toxins, and some cholesterol. Now again, this is produced by the liver, but stored and concentrated in the gallbladder. So that is a product of the liver. Pancreas, again, the endocrine pancreas is going to give us insulin and glucagon and some other things, but the exocrine pancreas has our digestive enzymes like amylase and lipase, trypsinogen for proteins, and then cholecystokinin and secretin, which we'll worry about elsewhere. Now, when we start to develop gallstones, a major issue for gallbladders is going to be gallstones. There's going to be a sequence of events here. The precursor is probably genetic. There can be a dietary precursor, but there's also possible genetic precursors. So here are the genes. I'm not going to have you memorize what these genes are. But overexpression or underexpression of certain genes can make this next process more likely. First thing we need is supersaturation of bile. Remember, we're already concentrating the bile in the gallbladder. That's its job. That's what it's supposed to do. But supersaturation of bile means that we're over-concentrating it. We're precipitating cholesterol. Now that precipitated cholesterol is going to undergo a process called nucleation. It's going to crystallize. And then with hypomotility and stasis of bile, that's actually going to allow those crystals to accumulate and grow into stones. So supersaturation, nucleation, and stasis with hypomotility. Has anybody seen the Awkward Yeti for this? You can actually get a plush toy of the gallbladder with a bunch of stones that it makes. Isn't that cute? I mixed these. Okay. So there's a gallbladder that's been removed and contains a very large number of stones. Again, those can be variable in size. We've already talked about kidney stones, how one large stone may just hang out. One large stone can cause pain. But what we're really, really deeply concerned about is if a smaller stone or a piece of stone breaks off and mobilizes through the system of ducts, right? So chronic cholelithiasis, that's going to be chronic and ongoing gallstones. That's going to be intermittent obstruction of the cystic duct. That's going to cause epigastric or right upper abdominal pain. Sometimes it'll radiate to the back. Nausea, vomiting, sweating, flatus, which is farting. And a fatty food intolerance, remember the purpose of this is to break down and transport fats properly. So if your gallbladder is not working properly, you are going to have a bad time with fats. You're going to need to limit your fat intake, space it out properly. Now, cholecystitis just means inflammation of the gallbladder. Very frequently, it's going to be because you have gallstones. Gallstones first, then cholecystitis. So acute cholecystitis is going to be short-term. Most of the time, 90% of the time, it's because of gallstones, and that can then progress into chronic cholecystitis. Now again, that does mean 10% of the time somebody has inflammation of the gallbladder without accompanying gallstones. So that's a little weird, but it could just be because of a bacterial infection. That's all you need there. One thing we worry about with gallstones, let's go back to this biliary apparatus, and we'll go back to this papilla vater right here, where we have mobilization of stones if that makes it to the hepatopancreatic papilla right there. If it gets it to that junction, not only are you going to have a lack of flow of bile, you can also back up pancreatic fluid into the pancreas. Ouch, yes. And again, what's in our pancreatic fluid? Digestive enzymes. And what are your cells made out of? Everything we want to digest. Yeah, your food is made out of proteins, carbs, lipids, nucleic acids. You are also made out of proteins, carbs, lipids, and nucleic acids. So if you have suddenly a whole bunch of pancreatic fluid flooding in your pancreas, stuck there, your pancreas can start digesting itself. Yeah, autodigestion. Yeah, there's an enzyme in pineapple that when you, yes, in Mother Russia, pineapple digests you back. Yes, exactly. So that's not the only case that would lead to autodigestion. All you need for autodigestion of the pancreas is inflammation of the pancreas. Gallstones would just be one way to get that. If we just inappropriately activate those enzymes, if there's something going wrong with the function of the pancreas, then those enzymes can be loosed on the pancreas and it can autodigest. If there's biliary tract disease, hypertriglyceridemia, that means too many triglycerides, eating too much fat. And then ethanol associated, a polite way of saying you're a chronic alcoholic and you've damaged your pancreas. So most of the time, our pancreatitis is going to be ethanol associated. It's toxicity, just straight toxicity of alcoholism. So let's zoom in on this acinar cell injury, very literal. So again, the acinar cell, when we say acinar cell, the acinar term is referring to the arrangement of the exocrine gland. It's that sort of berry-shaped arrangement. So it's the acinar cells as opposed to the ductal cells. You can't see my cursor right now. So these are the acinar cells and the ductal cells. So literally these things can physically damage the acinar. Let's go back. Alcohol, drugs, trauma, ischemia, or viruses physically damage the acinar cell injury. And then we're going to, as a response to that, those acinar glandular cells are physically going to be releasing their contents, those enzymes, those things that break things down. They will then break you down. Like we said earlier, having cholelithiasis, having a gallstone can physically break that back up. Once again, this can be associated with chronic alcoholism. And then in some cases, defective intracellular transport. Once again, alcohol is going to be something that could cause defective intracellular transport. And once again, duct obstruction can cause that too. But it could also be metabolic injury. All of this leads to more acinar cell injury, which means we're going to have lesions, we're going to have autodigestion, we're going to have pancreatitis. Did that answer your question from earlier? Okay. Manifestations of acute pancreatitis, steady boring pain in the epigastrium or left upper quadrant. Now again, the tail of the inflamed pancreas, that's going to be diverted to the left. That's why it's left upper quadrant. When you're palpating the pancreas directly, that's going to be painful. The ascites that can develop as a result of a leaking pancreas, literally you're leaking pancreatic fluid into the abdominal cavity, the ascites itself would not be a painful event. Yes, it's pancreatic fluid in the peritoneum, that's going to be damaging in its own way, but the mass will be painless. So palpating this guy's abdomen itself should not be painful until you get to that actual pancreas. Palpating the pancreas would be painful. I'm clarifying that because it's a frequently asked question about this. It says right here, severe tenderness on palpation, and then for ascites, it says it's painless and massive. Ascites is painless, pancreas is painful. What's that? Localized pain. Yeah, you can do this, you just, not that. Exactly. Or you can, but it'll hurt. So again, back to this concept of pancreatic ascites. Ascites being the general term for fluid in the peritoneum. Sorry, pancreatic ascites specific to pancreatic fluid. So you've damaged the pancreas enough that the pancreatic duct is literally leaking out the walls of the pancreas. I don't think this is directly fatal. I imagine if you didn't treat it, it would eventually be fatal. Yeah. Yeah, it'll start digesting you, that's for sure. What's up? Can you live without your pancreas? Good question. Without medical intervention, absolutely not. With medical intervention, you would need, you'd need all the endocrine stuff replaced. And there would be some severe imbalances even if you got your glucose metabolism under control. And then you would need all of your enzymes replaced. And so I don't know what those medical interventions look like. I would recommend not, not trying to. Probably. Yeah, and this is, remember, acini, exocrine glands, those are epithelial tissues. That means they can have mitosis, they can heal. It's vascular tissue because of that endocrine component especially. There's a lot of high regenerative capacity here. So I imagine there are a lot of health interventions that I'm completely unaware of since I'm not a clinician. So I would go into Karen or Ashley's class and ask about what we do for chronic pancreatitis if it's too damaged and we've destroyed it. Mm-hmm. Yeah. Mm-hmm. Yeah. Okay. So you'll give enzymes, you'll stop the natural processes of the pancreas. And was the suction just to remove the fluid or was there a different suction? Yeah. Just for the recording since your voice is quiet. Okay. Let's see. Chronic pancreatitis Ethyl alcohol consumption is a major predisposing factor. Surprise! Um, but it can progress even if alcohol consumption is stopped. If somebody was an alcoholic and now they've developed chronic pancreatitis, we've already started the downward spiral. It may not be reversible just by stopping the alcohol. That being said, don't continue the alcohol. It's not going to help. Now, pancreatic cancer, and you're kind of done you a disservice here. There's pancreatic acinar cancer, and today we're talking about the acinar portions of the pancreas, the exocrine portions. Acinar cancer of the pancreas is very, very deadly. It's only about 2% of cancers, but it's the fourth amongst deaths from all malignancies. So this is the pancreatic cancer that people are afraid of. The pancreatic cancer that Steve Jobs had was pancreatic islet cancer. That was the endocrine cells of his pancreas were cancerous. And that has a survival rate, a 5-year survival rate of 95%. So when people say, I have pancreatic cancer, you have to ask acinar or islet. Those are two very, very different cancers. There should be back on here, acinar cell injury. Alex Trebek, he has acinar. He has the bad one. Yeah. Did you guys see Alex Trebek's sort of speech about, don't worry about me, I'm going to fight this and fight this hard? Actually, I think at the time of writing about the time your textbook was written, or a little bit before, at least the old edition, it was a 5% survival rate. It's now up to 10% survival rate for that kind of cancer. They have improved the odds since then. That having been said, his chances are not good. Unless there really is a conspiracy and rich people are getting a different cancer treatment than the rest of us, then right. I'm not going to put it on the recording, but we finish the pancreas with pancreatic cancer, and then we discuss conspiracy theories about healthcare. Now we're going into the liver. Liver is a big deal. I really want you to understand that liver. The liver is so important for you to understand everything that it does, and therefore the outcome if it fails. Because the outcome if it fails is going to be everything. Big for farm, big for everything. So let's look at just the anatomy first. We do have a dual blood supply. We have its own arterial blood supply, but most of the blood that's flowing through the liver is from the hepatic portal system, the hepatic portal vein, taking all of those things that you absorbed from the mesenteries, things that you absorbed across the intestinal epithelium, taking them to your liver first for processing, for metabolism, right? And again, metabolism is a combination of breaking down and then building up all of our macromolecules of life. Anatomically, how many lobes do we have? 2 big ones and 2 small ones.
I was going to say 4, but that felt wrong.
It's 4. You have a right and a left. Those are the obvious ones. But then if you turn it over, you've also got a caudate and a quadrate. Yep, it's 4. It's 4 of them. Okay, you've got some attachments. You've got, for example, the falciform ligament. This is closely associated with the vena cava. So you have the hepatic portal vein going in, and then you have the hepatic veins going out back to the inferior vena cava. That vena cava is just straight through it, and that does have clinical significance to you. Let's see, what else do I want to say? Close association with the esophagus as well. We got the lobes, we got the structure. We're sort of illustrating the rich capillary beds. The liver is a very vascular organ, and I'm now going to repeat that phrase 5 times. The liver is a very vascular organ. The liver is a very vascular organ. The liver, its nature is that it's very vascular. There's so many blood vessels in your liver. It's a very vascular organ. Okay, I'm done now, but not really. I'm going to keep repeating that. So again, you've got the hepatic portal vein. that's picking up from the capillary beds of the mesenteries, delivering to the lobes of the liver for metabolism, back to the hepatic veins, back to the inferior vena cava. So there's your first pass metabolism right there. It's a very vascular organ. If something goes wrong with the vasculature in the liver, it's gonna be a very big problem. Do we all agree with that statement? Okay. Excellent. Very vascular organ. Now remember, this is the organ that is creating the bile salts. The gallbladder is just holding it and concentrating it. Without your liver, you would not have bile salts. It's going to process and store fats, carbs, proteins, vitamins, minerals. It's going to have endocrine function. It's going to be part of your glucose metabolism. It's going to be part of breaking down some of your old hormones. You're actually going to get rid of excess norepinephrine, just as an example. You're going to break down things that have been circulating because it's a very vascular organ, right? If you've been in fight or flight, you don't want to be in fight or flight forever. Eventually, we have to break down that norepinephrine. So your liver is going to help with that. It's hematological. We're going to store some blood. We're going to remove bilirubin. So we're going to break down red blood cells. And when we do, we're going to have some bilirubin left over. That's a waste product. We need to get rid of it. If we don't get rid of bilirubin, what's that? Jaundice. During fetal development, you're actually creating red blood cells with your liver. Not as an adult. That's all coming from your red bone marrow as an adult. But during fetal development, hematopoiesis is happening in your liver. Synthesis of blood clotting factors, factor 9, factor 10, factor 8, factor number. Fibrinogen is also a blood clotting protein that is synthesized by your liver. Guess what else is synthesized by your liver? Albumin. So imagine no albumin. What's up with that? Edema. Imagine no clotting factors. What's up with that? Hemorrhaging, bleeding problems. Okay. Excretory organ detoxification, like we're detoxifying and clearing bilirubin, we're also detoxifying drugs, foreign substances, alcohol, detoxification of and conjugation of urea into something that can be urinated out, right? So what happens if you can't clear your urea anymore? Infections, you're going to have a buildup of nitrogenous wastes. You can't clear alcohol. Alcohol is just going to keep circulating. Elevated bun, probably. That's more for kidney development, but I wonder if it goes for this too. Okay, so something that's going to be on your worksheet today that pisses everybody off, but I love it for the exact same reason, is that I'm going to give you a disordered state, and you're going to give me the normal function of the liver that would have prevented it. You have to go backwards. And that's what pathophysiology is, right? We take a normal organ, we mess it up, we get a disease state. I'm just making you understand it by going backwards. That's what I'm looking for. So I'll give you, for example, jaundice. What's the normal function of the liver that prevents jaundice? Clearance of bilirubin. So you should give me clearance of bilirubin. What you should not give me is improper bilirubin clearance. Does that make sense? So you're giving me a normal. You're giving me a normal, healthy state of the liver. Something normal the liver does on that table today. And by the way, the liver is a very vascular organ. Smiley face. Okay. Now that we remember what the liver does, let's start talking about some things that can hurt the liver. So manifestations of liver disease, hepatocellular failure means you'll be jaundiced. You'll have decreased clotting factors. You'll have hypoalbuminemia. You'll have decreased vitamins D and K, potentially leading to a condition called osteomalacia, which is going to be very poorly formed bones. Problems with vitamin K. Have you done vitamin K cycle already? You've done vitamin K cycle for warfarin? Okay, good. Portal hypertension. The liver is a very vascular organ. So if the liver is failing, that those blood vessels will become congested, and there will be a backup of blood before that organ. Where's the blood before that liver? Where? In the GI tract. It's portal hypertension, the hepatic portal system. The hepatic portal vein takes blood from the mesenteries to the liver. So if you have portal hypertension, if you have a buildup of fluid in the liver and things are backing up, it's going to build up in your mesenteries, in your abdominal cavity, in your peritoneum. Now, here's the thing about your veins in general. You have more veins than you have arteries. You have more ways to get back to your heart than you have to get away from your heart. So one thing that you could see when you have GI congestion is they're called gastric varices. So these are veins on the superficial abdominal wall that are returning blood that should be going through the liver, but it is now instead going through the body wall.
Medusa's head, or like Medusa's head. Cat killing Medusa. It's like this picture where like the blood vessels get all big and the stomach is really distended because like the liver's all messed up.
I've not heard of that specific thing, but that would be part of portal hypertension. Apparently there's a very specific one to the stomach, to the gastric veins called Medusa's head. That's what you said?
Right. It has a weird name, but that's what it translates to.
Gotcha. Okay, so back to this idea of portal hypertension. What's the normal function of the liver that would mean that you don't have portal hypertension? It's a very vascular organ. Yeah, it's a very vascular organ. Okay, like we said, jaundice is going to be because of improper bilirubin conjugation. That would be the hepatic cause. There can also be pre-hepatic causes. If we're destroying a whole bunch of red blood cells all the time, maybe you have sickle cell disease or something like that, that could lead to jaundice as well. Post-hepatic mechanical obstruction of the bile ducts. Again, we're just not clearing the bilirubin, so it gets stuck. We're going to focus on the liver breaking down the bilirubin for jaundice. Yeah. Portal hypertension, like I said, varices are going to be a problem related to veins outside of the liver taking on the blood supply outside of the liver, right? Other blood vessels taking over that job. Yeah. 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 Now, varices, these are the superficial, obvious ones. Somebody picks up their shirt, you know they have portal hypertension because they have gastric varices, or they have abdominal varices, rather. They can be in the esophagus. Let's look at this blood supply real quick. So blood supply returning to the liver that gets backed up. We do have the esophagus draining to portal fluid, right? So we can have what we call esophageal varices. So here's how that would look functionally. We'll have that sort of, that varix is what it's called, almost like an aneurysm located towards the inside of the esophagus wall. And that's going to be very prone to being broken open and bleeding. So esophageal bleed. Hemorrhoids, we'd also have some veins coming from the anal region. So hemorrhoids, gastric, they can rupture and that can cause uncontrolled bleeding. Even though it is the vein and it's lower pressure than an artery, we do have more blood volume there. You guys know you have more blood volume there. Okay, got all of that. Any questions there? Okay. Now, when you have too much ammonia, your liver is supposed to help you clear away urea and ammonia. That's its normal function. When you can no longer do that, you have a buildup of ammonia, and that can cause a neuropsychiatric syndrome. You have ammonia now in your brain. Ammonia is not supposed to be in your brain. So now you've got a neuropsychiatric syndrome. Dementia, psychotic symptoms, which when we say psychotic, we mean separated from reality. Psychosis is a separation from reality. We'll talk about that during our mental health week. Then cerebellar and extrapyramidal signs. Who knows what cerebellar signs look like? Low balance, wide gait, stumbling. Yeah. It looks like when you're detoxing from alcohol. So one thing that alcohol does is it suppresses your cerebellum. So here's the thing. You're in hepatocellular failure because you were a chronic alcoholic. And now, even when you're not drinking alcohol, you have an ataxic gait, as though you were drunk. Right? Fun times. So preferably we would clear that ammonia. We can also have ascites. We had pancreatic ascites. Now we're going to have ascites as a manifestation of liver failure because, again, it's a very vascular organ. We don't have the blood flow going through it. We have a backup and sluggish return blood flow. That literally just means fluid is going to accumulate in that cavity. It occurs because of portal hypertension, also because of hypoalbuminemia. And you know exactly why that is. Because we've been addressing albumin since day one, right? Everybody's totally comfortable with hypoalbuminemia. Good. Cerebral edema, again, because we have low albumin, because we have hypertension, cerebral edema.
With the hypo, that one. So obviously, would you call like edema hyper? Something? Do you ever call it, address it that way because the albumin is misplaced, or is it just?
So this is low development and synthesis of albumin.
Oh, okay.
So you are low in albumin in this case. It's
Okay,
not
so,
inflammation is the one that would put albumin outside of the capillary bed.
So what would it look like if you saw it?
In terms of tests or visually?
Because like edema, if you have too much and it's misplaced, you can see that swelling. Like,
You'll see the swelling. It's just because of a lack of osmotic pressure returning it to the bloodstream.
Oh.
Yeah. Do you want to draw the arrows? We could do the arrows.
No.
I recommend to make it make sense drawing the arrows across a capillary bed.
Okay.
But we've already done that in other classes. Let's talk about some hepatitis. Hepatitis, again, is a general term for inflammation of the liver. A lot of things that can cause hepatitis. Among them, there are 5 variations of virus that can cause hepatitis. So these are all viral hepatitis. Hepatitis A, B, C, D, or Delta, and E are all virus-caused inflammation of the liver. Now, just like we had with, let's say, our 5 kinds of antibodies, our 4 kinds of hypersensitivities, all of these are viruses that can cause inflammation of the liver. So I recommend you focus on the differences between them. Right? The big differences are going to be mode of transmission, the incubation periods, the time frames, whether they're self-limiting or end in end-stage liver disease with cirrhosis. Those are going to be the differences between these different hepatitis. So we'll start with hepatitis A, HAV or Hep A. This is usually spread by the fecal-oral route. This is the guy who made your salad did not wash his hands after using the restroom. Yeah, I mean, it just happens every once in a while. This is the one my sister got when we lived in Bolivia at the age of 12. She's okay, she's alive. It is a self-limited course. There's actually a joke at the pathology conference. Sometimes self-limiting just means they died. But if you don't die of it, you will heal from it. Your immune system will kick its butt eventually. Hepatitis B, blood or blood products, contaminated needles, sexual contact, sexual content in this podcast, whatever. Let's see. There's a large prodromal period. It can be very asymptomatic for a period of time. I don't really have anything to add to Hep B. Hep C is pretty significant to you. So Hep C, most associated with IV drug use. Blood transfusion prior to 1990 is also a possibility. The thing about Hep C, it could be the acute form, your body could kick its butt, or it could progress into a chronic HCV infection. There are people who are not able to completely fight off the hepatitis C virus, and are living with it. This is our most common cause of end-stage liver disease, is Hep C. Part of the problem there is it can be asymptomatic until the liver disease is advanced. Hep D, or Delta, on its own is not that bad, but if you have Hep B, it's going to worsen and accelerate that infection. And then hepatitis E can be spread just through contaminated water or by blood products. And it's going to be much more common in developing countries if you ever end up doing a Doctors Without Borders type of thing. High mortality rate in pregnant women. We're going to worry about Hep E, especially in cases of pregnancy. And that's about it. That's all I got for the different hepatitises. Viral hepatitises, I should say. So again, something like Hep C, what's up? Yeah, either you fight it off or it becomes chronic and you have it forever. I know somebody, it's kind of, I know a guy who knows a guy, but I know somebody who's living with Hep C, and she's had some really crazy interventions for her Hep C. She refers to one of her interventions of chemotherapy. She didn't have actual chemotherapy, but it was on par in terms of how destructive it was to her body, trying to get rid of this hepatitis virus. And she's still chronic. Yeah. Yeah, like for example, Hep A, self-limiting. You're gonna either die or you're gonna heal. Die or heal. Most likely heal, but death is possible. For my, was she 12? Yeah, 12-year-old sister, it was much more dangerous. It was pretty dangerous for her. Yeah. There are vaccines for these. We all went out and got the Hep A vaccine. That was 1992, so yeah, we've had vaccines for these for a while now. For some of these, not all of them. It was probably a restaurant. It's La Paz, Bolivia, so we had cows wandering the streets. Yeah, every once in a while. And we did some traveling around, and we got to pet a tapir and a bunch of other and some birds and monkeys and all kinds of things. Good times. But also lots of disease exposure. So many. And I was 7, so I was completely oblivious. Okay, now again, you can have the viral hepatitis. They can be persistent, they can be active or not. They're also autoimmune forms of hepatitis. Your body can start destroying your liver. So there's a liver with some severe cirrhosis. For our autopsy visit, very frequently we've been able to see fatty livers. We've seen a few healthy livers. I haven't seen a full-on cirrhotic liver just yet. I have seen some enlarged livers. This is not expressing how large livers will get with liver disease and cirrhosis. And part of that is blood accumulation, literally. So cirrhosis liver is fibrotic, scarred, and nodular, and that will be permanent alteration in hepatic blood flow and liver function. Right.
But there were some that was like not doing alcohol. Would it the second option or the second most common would be the hepatitis, maybe?
If it's not alcohol, hepatitis, Hep C would be a common form. And then I think I actually moved our metal storage diseases to genetic. I think we had Wilson's disease, for example. We had improper storage of copper and improper storage of iron that when I stuck them back in genetics, so they've actually been moved from here. So that was kind of the problem with rearranging it, right? I kind of warned you back then, okay, we're going to talk about the genetic metal storage diseases now, but we haven't had digestive lecture yet to fully understand the implications of having metals, heavy metals, toxic metals stored in the liver and destroying the liver. So all the outcomes of those genetic metal storage diseases would be cirrhosis of the liver and end-stage liver failure. Okay, so yeah, hepatitis, metal storage diseases, or alcoholism being the one that, presumably people are doing to themselves, behavioral. Although there's a lot of discussion we could have about addiction and what that is. That goes well beyond, just stop drinking. Question? Comment?
I was just telling my child, I think you have to be sober for like a year exactly to be allowed on the transplant list for liver.
Yeah.
If that's the reason.
Right, with chronic alcoholism, we punish alcoholics by not putting them on liver transplant lists, and it makes sense behaviorally, even no matter how nuanced our approach to alcoholism. It's an addiction, and addiction is very real, and there is a very, very high relapse rate. Absolutely. Okay. Yep. Yeah. Oh yeah. The science goes back and forth on alcohol all of the time, and it's in some really ridiculous ways. This is another reason that you should all get really comfortable reading materials and methods sections of papers. So you watch the nightly news. 1 glass of wine is healthy. 1 glass of wine prevents cancer. 1 glass of wine causes cancer. Chocolate causes cancer. You're addicted to chocolate. Chocolate is just as addictive as cocaine. Cheese is just as addictive as cocaine. Like, you need to go back to the materials and methods section to figure out what they were getting at. You have to be able to read the primary literature. That's the point of your research paper, is I want to make sure you're going back and reading that entire research paper, somebody's hard work and their materials and methods, and I want you to assess it too. Did they do good work, or is it full of S? I'm just going to say S because I'm on a recording. Full of S. Fancy right now. Okay. Because some of these papers are full of it. So there was one paper a few years back that said, actually up to 2 drinks a night for men is going to decrease your chance of dying of all of these things. But then I kind of looked at that and I read, is it decreasing your chance of dying of anything other than alcoholism? Because they didn't address that. And it's just science's reporting that's really just messed up and is not nuanced, and they're not understanding materials and methods sections. And so now there's a more recent one that says, any amount of alcohol is dangerous. Any amount of alcohol increases your chance of dying of various things. Yeah, it's toxic. It's literally toxic. It's not good for you. There's antioxidants in wine. There's also those same antioxidants in grape juice. Like, you don't need to go to wine for that. You could also eat grapes, and that would probably be ideal in that situation. So it just goes back to science's reporting, why that's all confusing. And get good at materials and methods sections. I know they're the most boring part, but they're the most important part of the paper. It's where you can go and be like, wow, this person's an idiot. They're dense. Yeah, but you get the most out of it. Okay, so biliary cirrhosis. You can also have obstructions. One source of an obstruction of the biliary tree, that very vascular liver, is what we're talking about. Lancet liver flukes. Parasites are more common than we would like to admit. Less common in the first world, but not unheard of in the first world. Let's see. Alcoholic fatty liver. We've seen plenty of these on autopsy. Maybe not quite that large, but definitely some big ones. Toxic liver disorders, any toxin can, remember, this is the first place it's going after you absorb it. So let's say, there's our hereditary hemochromatosis and Wilson's. Those were the ones that were removed back to our autoimmune, or sorry, not our autoimmune, yeah, our genetic section. But acetaminophen poisoning is still here. Acetaminophen, as you know, is Tylenol. Acetaminophen is one of the most dangerous things we have in our drug cabinets at home. Our lethal dose is only a few times higher than our effective dose, is what we're saying. And that the amount we have to take to have it cause any change to our perception of pain is going to be only a few times smaller compared to the amount that's going to start destroying cells of our liver. So this is a histology slide showing you some death of hepatocellular cells, or hepatocytes, I should say, liver cells, dying as the acetaminophen is brought from the mesenteries to the liver for processing. Liver malignancies. I got to see one of these a little while ago, actually. So liver is it's a very vascular organ, by the way. It's a common site for metastasis of other cancers. So if you have esophageal cancer, stomach cancer, colon cancer, rectal cancer, breast cancer, lung cancer, it is very likely that it will at some point metastasize to the liver. Because it's vascular and the lymphatic system. We have lacteals going there too, right? So they're both very, very connected to this very vascular organ. Are you enjoying that? The repetition there? It's good repetition. Now again, we can transplant livers and we can also do partial liver transplants. In fact, your liver is highly regenerative. Your liver can take a lot of abuse, in fact, before being completely destroyed. You can heal quite a lot of it. You can remove as much as 80% of your liver and heal from that. I'm sure they can. I don't know how much they worry about side of transplant. They probably do. I imagine the harder part about transplantation would be how vascular the liver is. So you're going to have these branches. You're going to have specific branches supplying the different lobes of the liver, right? So if you're removing half the liver, we've got to cut off very specific branches in order to do that. And again, I'm imagining what the challenges would be. So I'm not entirely sure what their thought process is with that, but that would be my major concern, would be the vascularity of the liver. Okay, that cirrhosis can get pretty severe. Hopefully not that. No, ma'am, I agree. That's a liver. And again, your textbook likes the extremes. I've never seen this on autopsy yet. Knock on wood. We'll see. I mean, how did that megacolon fit in a person? Yeah. Yeah. People fit some weird things. Last topics, some pediatric conditions. Let's differentiate kernicterus from abnormal bilirubin metabolism of the neonatal period. One of these is serious, one of these is not. Serious? Not. So physiologic jaundice of the newborn. It just means that they're newly born, their bilirubin conjugation, their metabolism of bilirubin, their bilirubin breakdown and clearance is immature. They just have a little bit more bilirubin than the next kid, right? And as I understand it, the treatments for this are really benign. It's something like UV light exposure. It's a light. You shine a light on them. They're fine. Set your kid in your sun. There you go. Sunlight. Kernicterus is different. It's still about bilirubin, but it's hyperbilirubinemia. Bilirubinemia. There we go. Said it better. Now, in this case, the immature blood-brain barrier allows unconjugated bilirubin to enter the brain, resulting in encephalopathy. It's associated with preemies, premature birth. There will be neonatal jaundice, possibly a hemolytic disease of the newborn. Remember that incompatible Rh factor could be playing a role in kernicterus. If that bilirubin makes into the brain, that it can be lethal. This is a lethal condition, as you can see from the fact that we have a cross-section, a coronal section of this infant's brain. This is not an alive infant. And you can see the yellowing of the brain from the presence of bilirubin. Right, so very different things with similar sort of initial manifestations of jaundice. Yes?
Would this ever have anything to do with toxins or anything throughout the pregnancy? Like, how does this?
Good question. If that premature birth was associated with some kind of traumatic experience during pregnancy, maybe. Otherwise, I'm not sure. I'm just going to finish these last few slides because we're almost there. Rye syndrome, primarily a disease of children. So what happened was a kid under the age of 12, most likely, got sick with a viral syndrome. They had a virus. And then they were given aspirin, which is salicylate, something like that. Salicylic acid. Salicylic acid, or close to salicylic acid. That combination in the young can cause, for some reason, kind of hand wavy here because we're not entirely sure why, can actually cause infiltration. Let's see, we're going to have some hepatitis, we're going to have some cerebral edema as a result of that. So it's a combination of the virus and the silicate. A little bit poorly understood. I did look into this to try to clarify exactly why that was happening, and it's not well understood. This is why we don't give aspirin to kids under the age of 12. That's all. Just don't give your kid aspirin. And then finally, congenital liver diseases. There can be enzyme deficiencies. Those would affect other organ systems as well. There's our friend alpha-1 antitrypsin deficiency. We saw him over in the lungs, causing potentially collapsed lungs, emphysema, things like that. So it can also impact the liver, so can cystic fibrosis. Let's see, other metabolic pathways, ductopenic conditions, extrahepatic ductopenia. And that's it. Any questions before I turn off the recording? That's it. That's all. All right, I'll go ahead and stop recording. That's it.